Thank you. Thank you very much. Thank you.
Thank
All
you.
right, bud. Okay, guys, well, it's good to be here. Good morning. I hope everybody's doing all right and had enough coffee. We're going to speak with you today about colon and rectal cancer, and this is a cancer that definitely can be a preventable disease, or it can be diagnosed in its early stages if we learn to know the signs and the symptoms that we need to, and also if we undergo adequate screening. Let me give you a brief anatomy lesson here. First of all, this is anatomy of the GI tract. I don't have a pointer actually, but if you see this tube extending from the patient's head or the mouth, that's the esophagus. We have the stomach, which is the first intra-abdominal organ of the GI tract. We have about 12 to 14 feet of small intestine. Then we have the colon, which is approximately 3 feet long, and about 6 inches of rectum, and then the anus. So what we're going to discuss today is colon and rectal cancer, which is a cancer which develops in the colon, rectum, or anus. Basically, there are four stages of colon and rectal cancer. There is stage 1, in which the cancer invades partially through the colon or rectal wall. Stage 2, in which the cancer invades completely through the colon or rectal wall into the fat surrounding. There's a stage 3, which is a colorectal cancer irrespective of the thickness through the bowel wall if there are lymph nodes that are positive for cancer. That denotes a stage 3 cancer. Stage 4 cancer, as in any cancer, is cancer with spread to distant organs or distant disease. The epidemiology of colorectal cancer, for incidence and mortality. In the U.S., colorectal cancer is the third most common cancer diagnosis in men and women. You see these figures taken recently from the CDC. These are the most recent updated figures. In 2007, over 142,000 people were diagnosed with colon and rectal cancer, including over 72,000 men and close to 70,000 women. Deaths are over 53,000 and basically equal in men and women. In Louisiana, for the most part, our incidence is a little higher than the United States. Males of all races, if you see per 100,000 individuals, over 63% in Louisiana versus close to 53% in the U.S. Whites are higher as well, as you see. African Americans definitely higher, 77.1 versus 62% here in Louisiana. The Hispanic population is the only group here in Louisiana that is actually lower. Actually, the Hispanic population is fairly low here, but it is lower here in Louisiana. The rates in the U.S. in all states except Mississippi have decreased from year 2000 to 2003 to 2007. This incidence is decreasing by 3.4% per year, and death rate is decreasing by 3% per year during this time period as well. This is probably due to increased screening utilization in our country. So that in and of itself is very good news. Survival and prognosis. If you see this slide here, it describes basically the incidence with localized versus regional, distant, and unknown disease. There are 39% of the colorectal cancers are noted to be localized disease, or that would be disease confined to the primary site. Patients who are adequately treated with this stage of colon cancer have approximately 90% 5-year survival. Regional disease is defined as spread to regional lymph nodes, as I stated before, basically stage 3 disease. This is 37% of the cases, and approximately 70% of these patients have 5-year survival if adequately and properly treated. Distant disease, or stage 4 disease, as I've stated in the slide previously, approximately 20% of the cases, 11.7% of those patients survive at 5 years. So as you see, as the stage goes up, the survival is less. So the key in prevention is either avoiding the cancer or earlier detection of cancer. Also, there's unknown or unstaged, probably 5% of the cancers, with a 33% 5-year survival. Several risk factors for colorectal cancer, and we'll go over all of these. Age is a significant risk factor. Age 40 to 50, the risk increases progressively from that point. There's a sharp rise after age 50, and age 50 is the screening age for the average risk individual, and we will discuss this at length later in the presentation. 90% of colon cancers are diagnosed after age 50. From age 60 to 79, there's a significant increase in risk, 50 times higher than those who are age less than 40. There's also an increased incidence in the younger age population. If you see this, this is a abstract taken from an article in Cancer and Epidemiologic Markers journal back in 2009. It says there's increased risk of colon cancer per 100,000 in young individuals. They define young individuals in those 20 to 49, increasing from 1.5% per year in men, 1.6% per year in women from age 1992 to 2005. So overall, the cancer incidence seems to be a little lower, but incidence is higher in the young. Why is that? We're not sure completely. Possibly could be because of dietary factors, overall health of our younger individuals. Possibility. Personal history of inflammatory bowel disease is also a very significant risk for incidence of colorectal cancer. The two types of inflammatory bowel disease are ulcerative colitis and Crohn's disease. I'm sure you have heard of these diseases before. With ulcerative colitis, there's a probability of developing colorectal cancer that is 2% after 10 years of disease, 8% after 20, and 18% after 30 years. Crohn's disease also has a significant risk of increased colorectal cancer, but is a little hard to extrapolate the exact percentages, but it is significant. Increased screening surveillance is definitely needed in these patients as well. Personal history of adenomatous polyps also increases our risk. 95% of colon cancers develop from adenomatous polyps. So the personal history of removed polyps is associated with increase of polyps and colorectal cancer. So patients who do have a history of these polyps need to have an increased screening frequency over the average age and over the average risk individual. Personal history of colon cancer obviously increases one's risk of colorectal cancer. Regular surveillance colonoscopy is indicated to detect recurrent cancers after a curative resection. A family history of colorectal polyps or colon cancer also significantly increases risk as well. 20% of patients with colon cancer have a family history of colon cancer. Adenomatous polyps or cancer, colorectal cancer in first-degree relatives are at increased risk. So who is really at higher risk with first-degree relatives? Those who have a first-degree relative with colorectal cancer younger than 60 years old. First-degree relative would be parent, son, child, brother, sister. Common sense should be used, though, when using the age 60. You know, most colorectal cancers we know take years to develop and have probably been there for several years before they're diagnosed in many cases. So if someone has a father who had colon cancer at age 65, common sense would tell us that we're probably still at increased risk. 2 or more first-degree relatives with colon cancer or colon polyps at any age also increase our risk significantly. There are other many genetic syndromes that we have found over the last several years that even increase our risk of colon and rectal cancer even more. Hereditary non-polyposis colon cancer syndrome, Lynch syndrome, or HNPCC as it is commonly called, is an inherited disorder of a mutation in certain types of mismatch repair genes. These mismatch repair genes repair DNA damage. Types of DNA damage can ultimately cause cancer. Not to bore you with these genes that have been discovered are MLH1, MSH2, MSH6, and PMS2. There will probably be many others discovered. This is as far as genetics is concerned, we are learning more about this almost every day, every month. 75% of these patients develop colorectal cancer by age 65, and most develop cancer by their mid-40s. There's association with several other malignancies as well: uterine, small bowel, stomach, kidney, ureter, pancreas, possible CNS or brain. So, you know, a person needs to understand, you know, it is very important that we all know our family cancer history. You know, one may not may say, well, I don't have a family history of colon cancer, but yet Their mother had uterine cancer, their father had stomach cancer, brother had kidney cancer. They may have Lynch syndrome. They may be one who need to start colon screening yearly at a young age. So it is important that all of us undergo a very thorough family history of cancer. Familial adenomatous polyposis is another inherited genetic syndrome. These patients have a large amount of colon polyps, greater than 100. Some even have thousands. Most common age colorectal cancer diagnosis in these patients is 39, and almost all will have cancer by age 40. So if someone has a first-degree relative with this problem, or even second-degree relative, they should undergo consultation with their physician and very probably early screening. Aggressive screening starting for these patients begins at age 10 to 12. And a proctocolectomy or complete colon and rectal surgical removal is usually indicated by early 20s. But in my practice, we have actually had a patient in their early 20s who had a very advanced cancer. So this is a disease that has significant consequences. Risk of upper GI polyps and malignancies are noted in these patients as well. Attenuated FAP is a variant of this disease in which a patient has less than 100 polyps within their colon or rectum. They have a more proximal distribution. They're more likely to be on the right than the left side of the colon. So later age at onset, slightly lower cancer risk, and there's also a risk of GI polyps and cancers. Many of these patients can be managed with yearly colonoscopy at a really early age, with surgery indicated if questions arise as far as cancer or for prophylaxis. MYH polyposis is a type of inherited polyposis that is relatively newly discovered. This has been discovered within the last several years. It's an inherited syndrome as well. There's a much higher risk of colon cancer than the average population. Surveillance needs to begin in these patients at a young age as well, as you see here at age 18. They need frequent colonoscopy, at least yearly colonoscopy. Colectomy needs to be performed if polyps cannot be controlled endoscopically, or if there's concern of dysplasia or early or more advanced cancer, obviously. Juvenile polyposis syndrome is another inherited disorder in which patients predisposed to hematomatous polyps in the stomach, small intestine, colon, and rectum. Most of these polyps are benign, but there is risk of malignant transformation in these. The colorectal cancer incidence in these patients is 68% by age 60. The average age diagnosis is age 42. The reason I'm discussing all these genetic syndromes, it's another reason to really evaluate our family history to see if we are at increased risk for the average than the average risk individual. Dietary risk factors. Dietary risk factors play a very key role in the in colon cancer formation. Dietary fat, we know that saturated animal fat is definitely implicated in cancer formation in the colon and rectum. But we know that cancers with higher fat intake have higher colon cancer rates. Transplants who change eating habits develop increased risk. What I mean by that, individuals who grow up in, say, Japan, which have inherently low-fat diets and lower colon cancer rates, Japanese who have moved to the United States and who adopt our American higher fat eating habits, have the same higher colon cancer rates that we have in the United States. Red meat, high consumption of red meat, the literature shows, is associated with increased risk of colorectal cancer, up to 28% increase in colorectal cancer rates. So some red meat is good, but too much is not, obviously. Processed meats also have been associated with several cancers, particularly colorectal cancer, with high consumption showing a 20% risk in increased colorectal cancer rates. Well, I mean, I think that's really a judgment call. I mean, when we talk about processed meats, the hams, the turkey, the processed things that, ham and turkey in themselves aren't bad, but but the processed meats have substances in them that are preservatives. It's the preservatives in and of themselves that pose the higher risk. I mean, common sense would say, sandwich or two a week, probably not a big deal. But if you're sending your kid off to school with luncheon meat every day for their whole life, well, that's probably very significant. Okay. Well, I mean, yes, that is probably, some believe actually, though, that fat in milk is needed for adequate vitamin absorption. Now obviously, whole milk is going to be healthier for us than cream, than heavy cream. You know, I think common sense from that standpoint, too. I mean, in all of these things, I think moderation in a healthy, well-balanced diet is the key. Fruits and vegetables. Fruits and vegetables, as our mom told us when we were young, are good for us. Well, she was correct. Studies have definitely shown that high intake may be associated with lower colorectal cancer rates and other cancer rates as well. Fiber, in regions of the world with high fiber intake have lower colorectal cancer rates. And subsequently, when these patients move to areas of not the higher fiber intake, it's extrapolated that they will have higher cancer rates. There's been conflicting evidence in trials. This is something that's been studied for a long time. Many trials show that there's a significant benefit. Others don't show as great a benefit, but there's definite observational evidence that shows a benefit. Higher fiber diet usually indicates that someone has an overall healthier lifestyle as well. Increased patients who eat a higher fiber diet usually eat a lower fat diet. So once again, all of these things play in together. Increased fiber, decreased transit time in the colon. So that's really the theory, that if stools progress through the colon more frequent, at a faster rate, there's less time that the carcinogenic or cancer-causing substances are in the colon. That's why we believe that there's probably a positive effect here. Physical activity and obesity. Higher rates of physical activity are associated with lower rates of colon and rectal cancer. And this appears to be a dose-response effect. The greater the intensity and the frequency of exercise is associated with inverse risk, inversely with the risk. So the more intensely and the more we exercise, probably the lower our risk of cancer. Why is this? Well, it's been postulated the possibility of increased gut motility. We do know that exercise does increase our gut motility, probably increases our stool frequency. Probably the same theory as fiber helping us. It decreases the time that the carcinogenic or cancer-causing substance are in the colon. Obesity, there's inefficient energy consumption associated with increased risk of colon cancer. Cigarette smoking. Cigarette smoking is not really good for anything. Excuse me? Not really, no. I mean, I've cited a bunch of references for you at the end. I really don't have it in written form. We could probably have it printed up. I mean, we'd be glad to print it up or email it to you. Give me your email address, I can send it to you. Okay? Anyway, cigarette smoking, there are several carcinogens in tobacco which increase our rates of colorectal polyps and cancer, as well as many other cancers that we know. Lung cancer, increases our risk of heart disease, etc. Up to 12% of colorectal cancer deaths, if you really look at the associations, can be attributed to cigarette smoking. And in cigarette smokers, there's an earlier average age of the onset of colorectal cancer. Heavy alcohol consumption has also been found to be associated with carcinogenesis of colorectal cancer, and their occurrence at a younger age, just like tobacco. I mean, there's a metabolite in alcohol called acetaldehyde, among others, that are cancer-causing and carcinogenic. Moderation is the key here. 2 or more drinks a day seems to be associated with an increased risk. And the risk. Well, I think we would define that as a normal drink, I guess. I'll show you. I'll cite the. Well, 1 beer, 1 6-ounce glass of wine, one mixed drink. You know, with a normal, yeah. But I'll cite the article here that talks about this. This is from a very respected journal. This is the Annals of Internal Medicine, taken from 2004. They looked at almost 500,000 patients. So this isn't a small study. 500,000 patients in North America and Europe. And what they found, if you see the highlight areas, the increased risk of colorectal cancer was limited to persons with an alcohol intake of greater than 2 or more drinks a day. And this is it doesn't seem like a very high level. But the conclusion was that, alcohol intake is associated with carcinogenesis. Now, obviously, that goes up with more and more intake. Somebody who drinks 6, 10 drinks a day is going to be a lot higher than this. So moderation is the key, just like everything in general. Colorectal cancer screening and prevention. We know that 95% of colon cancers arise from colon polyps. There's a normal colon to polyp cancer which takes a long time. It probably takes 7 to 10 years or longer. There are some cases though where it can be quite accelerated. I don't want to bore you, but there's a de novo pathway where cancer is developed from the mucosa itself and not from a polyp first. That pathway is not common, probably less than 5%. The genetic traits or the genetic syndromes I discussed probably have faster rate of recurrence of colon cancer. But for the most part, colorectal cancers are slow growing that first start as polyps. This kind of shows this, the adenoma to carcinoma sequence. Of course, there's a normal mucosa of the colon. You start then to have a polyp over a certain, usually a long period of time. Severe dysplasia, mild dysplasia, moderate dysplasia, severe dysplasia, then cancer. There are several genetic mutations and defects that occur that can result in this over usually a long period of time. Yes, sir? It just varies. It probably takes some time. Ultimately only God knows, but we really do believe for the most part the polyp to cancer sequence takes a while. But there can be some accelerate, just like in medicine we say never say never, never say always. Things vary. But usually it takes some time. And the whole reason to explain all this to you is to show you why colonoscopy is the best screening preventive test. If we find polyps, remove them, you're not going to get dysplasia. You won't get cancer. So that's why colonoscopy is such a good screening and preventive test. Yes, sir? Yeah. Yes. Yeah. I mean, there are signs. There are early signs. Unfortunately, some patients have cancers with no symptoms whatsoever. But there are symptoms. There's bleeding, change in bowel habits. Sometimes it's vague abdominal pain. Some of these things can be signs. Now, as far as early signs, people can have small polyps, dysplasia, and even small cancers with no symptoms whatsoever. And that's why all these things I've discussed with you are really the key. If patients seem to believe they're in a higher risk category, they should be screened more aggressively than 50. Okay, and I'm going to discuss all these things. If I don't answer all your questions, please feel free to ask more. This is a very busy slide. I don't expect you to read this completely. These are the screening recommendations for colon cancer. Many different societies here, all with basically the same recommendations, but a little slight variation. This right here, though, is an excellent slide which explains what I believe are the best screening recommendations. And these are ones that are followed for the most part by all. You divide, and this is actually a pretty good website. I got this from stopcoloncancernow.com. You can divide the risk stratification into three groups: the average risk, the high risk, and the other. The average risk individual, as I've stated, is those that are 50 years old with no symptoms whatsoever, no bleeding, constipation, change of bowel habits, as I discussed with you. These patients, and there are also some literature that show that African Americans actually probably should be screened a little earlier at age 45. Now, unfortunately, because their cancer rates seem to be a little higher, if you saw, particularly in our data looking at Louisiana patients, African American patients were higher than the whites and the Hispanics. But insurance companies, Medicare, haven't bought into that yet. I hope so. I hope so. But in these patients, average risk individuals, of course, colonoscopy is recommended at least every 10 years, and I'll discuss that. Stool hemoccult cards, and I'll discuss the 3 different types, should probably be done yearly after colonoscopy. The stool hemoccult cards can look microscopically for stool or DNA, which I will discuss, which could give an indication for an earlier colonoscopy. The true recommendation for colonoscopy is every 10 years. What did I tell you about the colon cancer to polyp sequence, though, is 7 to 10 years. So, if someone wanted a colonoscopy 7 years after their previous one and they had no symptoms, I think it's warranted to do, because we do know that cancers can occur during that time period. And colonoscopy is a great test, but it's not the perfect test. Still, things can be missed. If you look at other options, colonoscopy is the best test. If for some reason someone refuses that or won't, the other option is a flexible sigmoidoscopy, which is a short scope while you're awake usually, and a barium enema while you're awake. Both of those tests combined still aren't as good as colonoscopy, and like I said, you're awake. And I'll discuss both of those at length. More so, virtual colonoscopy or CT colonography or CT colonoscopy is another option. Really is not really covered for screening. There are some indications for it, and I'll discuss that later. Still not as good as colonoscopy for evaluating colorectal polyps. For the higher risk individuals, and these are the individuals we are trying to find to try to screen them early to prevent colon cancer. And we find cancer frequently in patients age under 50. My own sister was diagnosed with advanced colon cancer at age 47. So we need to find those individuals so that we can screen them early and prevent cancer before the screening age. The higher risk individuals are those any age with a personal history of colon polyps or colon cancer, like we discussed earlier. First degree relatives with colon cancer or colon polyps before 60, common sense, still could be a little older knowing these things are there for a long period of time. Unexplained blood in the stool, indication to do colonoscopy right away. I mean, that is a true sign of possible polyp or colon cancer. Unexplained anemia or low blood counts. Cancers and polyps can cause bleeding over a very slow period of time that won't even be noticed in the stool. That definitely is an indication for earlier colonoscopy. Ulcerative colitis and Crohn's disease, we've stated. So, those higher risk individuals, of course, the stool hemocult probably indicated yearly after colonoscopy. Colonoscopy, in these patients is going to be more frequent than 10 years. After cancer surgery, this first scope is usually a year. And then colonoscopies at that point will be depending on what's found. Less frequent than every 5 years in those patients. And of course, those with ulcerative colitis and Crohn's disease, we know that the risk of colon and rectal dysplasia and cancer increases significantly after year 7 of disease. So usually we recommend yearly colonoscopy in those patients after year 7 of their disease because of that. This other category, other GI symptoms, vague abdominal pain, narrow stools, constipation, change in bowel habits, kind of to answer your question a little further. I mean, these are the patients that probably should have consideration for colonoscopy. We'll discuss colonoscopy further. Colonoscopy is the best screening and preventive test. It's the one screening test for cancer that can actually prevent. Most of screening tests for cancer only detect. Well, colonoscopy can prevent. Remember, 95% of colon cancers come from colon polyps. You remove polyps, you're not going to get cancer. In 1990, the Journal of the National Cancer Institute looked at sampling of or data associated with colonoscopy and the accuracy. There's a minimal risk of missing polyps greater than or equal to a centimeter. Those less than 5 millimeters, which is half a centimeter, it's only a 16% chance of not detecting. 6 to 9 millimeters is a 12.3% chance of not detecting. The smaller the polyp is, the significantly less risk that there's going to be a cancer associated with it. In the American Society of Colorectal Surgeons, which is my society, I'm a colon and rectal surgeon, my 2011 core subject update did a systemic review of colonoscopy throughout the years. We found that 1 centimeter polyps are greater or missed or not noted only 2% of the time. 5 to 10 millimeter polyps are not noted only 13% of the time, and 1 to 5 it says 26. But those 1 to 5 millimeter polyps are usually pretty insignificant as far as having cancer in them. As you're aware of high definition, all of us have high definition TVs now. There are now new high definition colonoscopes and high definition monitors. And the literature is showing that these probably give us the ability to see smaller polyps than we were able to see before. So I think we're going to see more literature come out about high definition and with these results even being better. Here's a little cartoon of a colonoscopy. Anyone who's had a colonoscopy has been through this. How does colonoscopy work? Well, the day before, the patient has to do a bowel prep where they have to cleanse their colon of the stool so we can see. Also lower the bacterial counts. The preps now are a lot better than they used to be. Years ago, there were the 4-liter preps, which is a whole gallon. Now there are several preps that are half of that, 2 liter, and there's even one prep that's less. The preps are fairly palatable. I've had to do a colonoscopy myself twice, so I can sympathize and empathize. I've done it myself. So it's doable. But for the test itself, someone needs to be brought to the endoscopy center or surgery center by someone. Scope usually takes 15, 20, 30 minutes, usually at the longest. Polyps can be removed usually if something is so large that it can't. We tell you what we need to do. I'm a surgeon. But the whole idea is prevention or early diagnosis. Because of the sedation that's given, people don't remember a thing. That's great. Because of the sedation, patients can't drive or work that day. Usually the next day they're fine to do whatever they would like to normally do. They can eat right after as well too. Clear liquids the day before, but right after the scope, regular diet. Go eat what they want. This explains colonoscopy to you a little further. As you see, the colonoscope enters the anus here. Travels all the way around the colon. Pathology is visualized. Polyps can be noted. Small to moderate polyps can be removed. Larger polyps or cancers, we note where they are. We're surgeons. We can tell you what we need to do to deal with them from there. We also make diagnoses of other problems. Inflammatory conditions, ulcerative colitis, Crohn's, diverticula, other pathology that are noted in the colon. Here is a colonoscopic view of the colon. This is actually the transverse colon, the part of the colon that goes across. How do I know that? The transverse colon endoscopically usually has more of a triangular lumen. This picture on the left is another view of normal colon. This right here on the right is a small adenomatous polyp. This is the type of polyp that's not removed that won't necessarily, but could over a long period of time grow and become a cancer. You see like that, you see a polyp like that is rather easy for us to remove and prevent cancer from occurring later in the future. Here is a picture of a colonoscope in removing a polyp using a snare. There are other ways we can use polyps. We can use a device called a cold biopsy or hot biopsy forceps. And the snare can be used for moderate to larger polyps, and sometimes to remove polyps in multiple pieces. This is what happens when a polyp is not removed. Years and years down the road, this is a colon cancer. Colon cancers have many different appearances, but this is fairly typical. This is a rather large, it appears to be an advanced one. These colon cancers like this cannot be removed with a colonoscope. Surgery would be indicated for this patient. CT colonography, or virtual colonoscopy, which many of you may be aware of, is another screening test. It detects polyps relatively well, 90% of polyps greater than a centimeter, 80% 6 to 9 millimeters, 65% less than 5 millimeters. There are false positives noted though in 17%. So if someone has a positive finding on CT colonography, obviously they would need a colonoscopy to follow it. Polyps cannot be removed with this test. Most insurance companies do not cover this for screening. Other drawbacks, there's fairly high radiation exposure from it, higher than a typical CAT scan. So if a patient is going to need a colonoscope multiple times in their lives, the cumulative radiation is something to think about. Bowel Prep is still required. Also, you are awake for this test. A balloon is inserted into the bottom, and then there's some air installation. Some discomfort, whereas colonoscopy you're completely asleep. For this you're awake, a little mild discomfort associated with it. There definitely is a role for this, though, for incomplete colonoscopy. Usually for colonoscopy, we can make it all the way around the colon without difficulty, probably 2-3% of the time. For whatever reason, patient's anatomy, what have you, we can't get all the way around. Well, we still need to assure that the rest of the colon is seen. Virtual colonoscopy in this case is great. And it usually can be done the same day as colonoscopy, so the patient doesn't have to have 2 preps. Though the radiation exposure is something to think about, so probably at least at this time, it is not the best test for screening. Here is a CAT scan reconstruction of the colon. As you see, the CAT scan can do a fairly good job of reconstructing the colon and denoting polyps, and this actually is a color reconstruction. Barium enema is another test that was used quite often in the past to evaluate for colon rectal cancer or polyps before colonoscopy. It was the main test used. It is a test for polyp detection for less than 1 centimeter is 50 to 80%, not so great. Greater than a centimeter, 70 to 90%. For stage 1 to 2 cancers, 50 to 80%. So still, up to half of the cancers can be missed. There's no sedation as well. A patient has a tube put in their bottom and they're instilled a large amount of barium, and then x-rays are taken. Has no ability to remove polyps. So this really is not the best screening test anymore. Though for someone who refuses colonoscopy, this in a short scope would still be an option. This is a picture of an x-ray of an air contrast barium enema. But as you can see, and multiple pictures can be taken, you can see how small, subtle polyps, flat cancers could definitely be missed. Fecal occult blood. Now there are basically 3 types of fecal occult blood that have improved over time. The more traditional, the older test is the fecal occult, the guaiac fecal occult blood test. Patient is instructed to collect samples and send them to the lab. There are some food and medication restrictions. Certain foods can give false positives. Beets for one. Aspirin is one that can cause a false positive. It can cause some mucosal bleeding in the colon that would result in a positive test. So it's fairly inaccurate. Many false negatives. So if a patient has a positive fecal occult blood test, it in and of itself doesn't diagnose cancer or polyps, but it gives an indication for colonoscopy. On average, about only 30% of colon polyps or colon cancers are detected, say if all patients were scoped endoscopically. Here is an article from 1993, Journal of American Medical Association, which basically looks at the accuracy of 2 types of hemoccult tests, or fecal occult blood tests, the hemoccult and the hemoquant. And as you see here, it was relatively low. For intraluminal cancer recurrences, it found it was only 21% of the time positive. All new primary tumors, 33%. Dukes A or B, that would be cancers that are partially or completely through the bowel wall. Only 29%, and the hemoquant results were even less. So as you can see, this in and of itself was not really adequate screening. The FIT test, which is actually offered, I believe, in screening today, is a significant improvement over the fecal occult blood test. And this is a test for fecal hemoglobin, much more sensitive than fecal occult blood. There are no food or medication restrictions. It's slightly more expensive, but is overall a much better test. Still, not to replace colonoscopy, but a much better test. This is a study which compared the FIT versus the more traditional fecal occult blood test. And as you see here, the FIT for accuracy was significantly improved. You see the highlight area in cancer, 87.5% versus 54%, significant adenomas, 42 versus 23%. Stool DNA is another test that is around, not readily available. I believe only one of the tests is FDA approved, basically only used at a few sites, but in the future, I believe this test is going to be brought to the forefront. It will be very important for colorectal cancer screening. Detects 85% of colorectal cancers and 2/3 of adenomas. How does it work? The stool DNA test is not reliant on blood. The polyp or cancer is not going to bleed all the time. So that's one of the reasons the fecal occult blood or FIT test can have false negatives. But most of these tumors shed DNA constantly, or that's the theory. So this appears to be much more accurate. For adenomas or benign polyps less than 1 centimeter, 31% detected. 1 to 2 centimeters, 64%. 2 greater than 2, close to 80%. And greater than 3 centimeters, over 90%. So there's much promise associated with this test. Of course, it'll be more expensive, but I believe it will likely in the future replace the other 2 tests. This is an article which just looked at the accuracy of one type of stool DNA test, and it showed an accuracy in diagnosing or noting cancers in 87%. This was for stage 1 to 3 cancers. Now a positive test, once again, will give an indication for colonoscopy, and that's how the cancers would be diagnosed. And for advanced stage disease, close to 70%. Now, our hope is to prevent cancer, or to make an early diagnosis of cancer. As a colorectal surgeon, we perform all of the surgeries to treat colorectal cancer or polyps that can't be removed surgically. There are minimally invasive approaches, the laparoscopic colon resection, hand-assist laparoscopic colon resection. I've done several of these, hundreds of these. Great operation. There's significant improvement of the minimally invasive colon resection versus the traditional open, although we need to do the traditional open at times. Smaller incisions result in less pain, probably faster recovery. Overall, less adhesions within the belly, probably less risk of bowel obstructions in the future. Patients just seem to, overall, after their initial period, seem to recover faster. This is basically kind of a cartoon depiction of a laparoscopic surgery. You see the patient here. You see the camera holder at the head of the bed. On either side is the surgeon using laparoscopic instruments versus the other, which is the assistant. There are also hand assist devices which allow us to use our hand to make, in my opinion, to make the operation faster, allow us to get higher node counts for our cancer cases, in my opinion. This is a picture of me in 2009. That's what this was. I know it's okay with my patients for me to show this picture. This actual picture was in the people section of the Advocate. The Advocate did a story on our cancer program at Our Lady Lake and Maryburg Perkins. But this shows you here I am on the right, my assistant John Sponduras, who's a surgical resident at the time. You see the monitors at the lake. We have rooms which are set up for laparoscopic surgery with monitors built in, etc. Also for rectal cancer, there's laparoscopic resection for hand-assist laparoscopic rectal resection, which I do as well. It's another procedure that one of my partners, Dr. Finan, and I both do for certain early stage rectal cancers and benign rectal tumors called transanal endoscopic microsurgery. This is a device which allows us to do resection of early cancers and benign rectal tumors without any incisions on the belly whatsoever. Scope is placed within the anus when the patient is asleep, as you can see using this instrumentation. Above is basically a cartoon depiction of this. We score the actual lesion. We actually excise the lesion, usually full thickness, and close it all through a scope that is about this big, 40 millimeters. It is a great operation. This is actually a view of the actual each step there below. As far as minimally invasive surgery, there continues to be advances in minimally invasive colon and rectal surgery. Of course, there's the advent of robotics for rectal dissection. The literature, for the most part, has shown that robotic surgery results are equivalent to laparoscopic or hand-assist laparoscopic surgery. So not really, the results aren't necessarily better at this time. But, I think there will continue to be advancements from that standpoint in the years to come. Chemotherapy and radiation. This is kind of beyond the scope of this, but obviously for colon cancer, chemotherapy is indicated for node positive and for patients with distant disease. Radiation is rarely indicated for colon cancer, certain cases with abdominal wall involvement where it's indicated. For rectal cancer, preoperative chemotherapy and radiation is indicated for low and mid-rectal cancers with stage 3, meaning through the bowel wall, and stage 2 through the bowel wall, or stage 3 with node positive disease known preoperatively. Really become the standard of care. Decreased local recurrence. There's also potential for post-op chemotherapy and rarely post-op radiation. But that's really beyond the scope of this talk. You could talk 2 hours about chemotherapy and radiation. You could talk 2 hours about surgery. Once again, though, highlights here. This is what's important for you guys. We're trying to prevent cancer, colon and rectal cancer. Average risk patients, it's colonoscopy, as I discussed. The higher risk patients. We need to do our family cancer histories, look for symptoms. Do we need scopes before 50? We want to make diagnosis of cancer earlier so we can prevent cancer. My own sister had cancer at age 47. Not too long ago, operated on a 32-year-old with cancer. Another patient with a 17-year-old colorectal cancer recently at the lake. So, we need to be aware of these other things that would make us a higher risk, that would give us the opportunity for earlier screening. Basically, in summary, risk assessment, as I stated multiple times here, family history, symptoms. Let's eat a lower fat diet, higher fiber diet, well-balanced diet. Well-balanced diet is better for us and basically for every disease process. Limit processed foods to the best of our ability. Limit alcohol intake. Avoid tobacco. Exercise. And appropriate evaluation and screening. So I appreciate your time.